I'm Kathleen McCann with the American College of Surgeons, and you're very welcome to How to Put Clinical Programs into Practice, a webinar sponsored by the International Relations Committee. A friendly reminder that questions for our two panelists are welcome and encouraged. Please submit your questions via the question and answer box, and they will be addressed at the end of the session. It's my pleasure to introduce Dr. AJ Jain, our moderator for today's webinar.
Hi, welcome to the session. The idea for this session came out of the fact that as international surgeons, we often encounter new ideas, new concepts, and oftentimes we want to bring these programs or some of these tools to our own programs. It may not even be something that you've seen abroad. It may be something you've seen in your own country or even in your own region, but at a larger center. And there are many barriers that can prevent us from moving forward. It can be barriers of credentialing, it can be barriers of infrastructure, it can be barriers of training. And today I have two surgeons who have successfully been able to bring novel programs into practice at their own institutions. The first one will be Dr. Barish Edil. He's the John Schilling Chair and Professor of Surgery at the University of Oklahoma. He began his career at the Johns Hopkins Hospital, where he was one of the innovators and developers of the laparoscopic Whipple's procedure. He later brought this program to the University of Colorado, where he moved as the division chief of surgical oncology, and now to the University of Oklahoma, where he serves as the chairman. And our second speaker is Ms. Ruth Delaney. She is an Irish surgeon, did her training initially in Ireland, her internship and her surgical house officer years before going to Harvard for her orthopedic surgery residency. And then she is now in practice in Ireland, in Dublin, and she has brought novel shoulder surgery techniques and practice to Ireland, and also serves on the faculty at the University of Dublin. So I welcome both of them today.
Thank you very much. Thanks, AJ. And thank you very much for having me here on this session. So thank you for organizing this and having me speak. I'm a shoulder surgeon in Dublin. And as Dr. Jain mentioned, I started out in Ireland. I'm from Cork on the south coast, and that's where I went to medical school and spent the initial 2 years after medical school. And after that, I applied for a US residency, not really thinking I would match as an IMG, but I got to spend the next 6 years in Boston. And also during fellowship year, I spent 2 months in France, in Annecy and in Lyon. Then I came back to Dublin in 2014 to start practice as a subspecialist shoulder surgeon. I was really fortunate to have a diverse training spanning 3 countries, and to have matched at a residency program that was my top choice and that really afforded me some great opportunities. And when we initially started talking about this webinar, I kind of felt a little strange because Dr. Jain and Dr. Edil are cancer surgeons, and they cure cancer, they save lives. And in orthopedics, it's pretty rare for us to be saving lives. Most of what we do is quality of life surgery, and certainly fixing shoulders comes into that category. The last time I probably did anything life-saving was as a chief resident on orthopedic trauma one April day in 2013. And then a few months later, I had graduated residency and suddenly was in the world of shoulder surgery. And these were my mentors in Boston and in France, who were incredibly supportive, both clinically and academically. And there were some real high points during that year. And like everybody, towards the end of your training, you have decisions to make about where to go. And for me, that was a big decision about whether to come back to Ireland or to remain in the United States. There were pros and cons to both, but probably the original shoulder surgeon in Ireland, the guy who had first done any shoulder surgery here of any significance, was looking to wind down and retire. And there were a set of circumstances that meant there would be a void left when he was gone and an opportunity to do a lot of shoulder work in Ireland. So I decided it was the best time to try to come back home. I think we all expect when we transition between systems that there will be barriers, there will be obstacles. And moving to the US to start residency, I think most of those challenges were things I anticipated. Even the residency application process, things like immigration visas, and just the culture shock of going from what we thought was a big hospital, like Cork University Hospital, where there's one set of elevators and 5 floors. And then you find yourself at MGH, where there's just a huge facility and it's a different scale. But all of that, I think when you have challenges that you anticipate, just like in surgery, if there are things you've anticipated, it's easier to deal with them and you handle them pretty well. When I moved back to Ireland in 2014, some of the challenges were to do with, first year in practice, which is tough anywhere. But some of the challenges were not things that I had anticipated. And I hadn't originally intended to really talk about this. And then AJ felt that actually, this is relevant to putting clinical programs into practice, because it's a barrier that you face to entry. It's obviously, if they don't want to give you a license to practice, you can't do what you want to do. And that's pretty much what happened, because I had done things differently and left as what we call a senior house officer, and then done all of my training in a different system. There were some issues. Some people in the licensing bodies had some issues with approving that training and actually decided to call that training inadequate. And I think, when you face challenges doing what you want to do, like anything, you pick your battles. This was a pretty big battle, but it was a battle worth fighting. And it was difficult. And it really, it got a little ugly at times, and there were lawyers. But in the end, I persisted, and it got sorted out. And so I was able to start practice right at the end of fellowship without any delay. This is the institution that I came back to Ireland primarily for. Sports Surgery Clinic in Dublin is a focused orthopedic hospital and a really high efficiency center. And it was the right place for a lot of what I wanted to do. It was also important to have another hospital that I could do some of the bigger things at, where we could have sicker patients, and a multi-specialty hospital. And initially that was another institution which was actually not the right place for a lot of what I wanted to do. And I think when you are trying to put clinical programs into practice, if the culture in an institution doesn't match with what you're trying to do, then you don't stay there, and a lot of times it's hard, I think, to switch and to make that that change. And now the other hospital that I work at is called the Beacon Hospital, which has an academic affiliation with University College Dublin, which affords a lot of great opportunities. And this is a big, also private hospital, but multi-specialty with full service ICU. And the combination of both of those places allows me to do what I want to do in practice. And so the things that I'm going to mention about shoulder surgery practice that I have instituted so far since coming back to Dublin, things like systematic tracking of outcomes, preoperative planning for shoulder replacement surgery, and some new techniques, including those to address massive irreparable cuff tears. I think most people in surgery have heard of Codman and know that over 100 years ago, he was thrown out of Mass General for daring to suggest that we as surgeons should be accountable for our outcomes and should report on them and be really honest and upfront about how our surgeries turn out. And today, thankfully, there's much more appreciation of that. And when I started in practice, this was something that was important to me. It was something that one of my mentors had felt really strongly about. JP Warner established the Codman Shoulder Society. And so when I established my practice at Dublin Shoulder Institute, I started using something called Surgical Outcomes System. And there are lots of different programs we can use. This particular one is email based, and so it sends the patient's emails to record their patient-reported outcome measures. Believe it or not, 69% compliance is actually a little bit above the global average. But I've just recently hired more admin staff, so we will have the manpower to chase up even more data and make sure that we can capture as much as possible. Particularly some of the older patients that maybe don't use email and things like that. They need more resources to help capture that data. One of the challenges with this was that nobody was doing this here. There were, sort of some clinical audits and things going on, but nobody was using an organized program like this. So it had to get approved by the Data Protection Commissioner for Ireland to allow this program into the country and to allow us to collect data in this way. And that took a little while, but again, this was something that was worth putting time into. So we enter the information on the patient's surgery. The patient answers the questionnaires, and for example, on a pain scale, this particular patient, his pain scale is better than the average in my practice, and also the global average. And it's really nice to be able to compare your outcome measures to a global mean as well of hundreds of surgeons around the world, so that you know that what you're doing is on a par with the standards that are out there. In terms of shoulder replacement, preoperative planning was something that made huge advances during the year of my fellowship, going from using a 2D CT scan to using a 3D program. I know that most people listening are probably not shoulder surgeons. When a shoulder becomes arthritic, the glenoid tends to wear preferentially posteriorly and starts to become more retroverted. And that creates some technical issues for us in terms of placing the glenoid component of an anatomic total shoulder. And it can lead to problems with loosening and early failure. And so it's really important to appreciate the retroversion and the other aspects of the glenoid morphology. But up until about 2014, we were using a method from the early 90s, just manually measuring on a CT scan. And then more programs became available where we could actually use 3D planning, patient-specific instrumentation even, and that would allow us to predict exactly what we were doing and learn the pitfalls before we actually were in the OR. So when I first came back, it was tricky. You know, there were surgeons who didn't even really believe in getting a CT scan before doing a shoulder replacement. But I was really fortunate at Sports Surgery Clinic that the head of radiation services there was really open to this. And I spoke to him and said, listen, you know, I need to have a slightly different CT protocol for my replacement patients. And here's why. And I think when you're trying to institute something new and have people change something, if you can show them why, then they're much likely to come on board with you. And the CT protocol meant including the entire body of the scapula and having CT cuts that were a little bit thinner than the standard. So yes, there was a slight bit more radiation, but you know, we went through the risks of that, and the risks were really minimal, and he was on board right away. And so every one of my patients is able to get blueprint planning now. And that shows us that often we've underestimated the retroversion, or we might be about to do the wrong operation. The patient might not be suitable for an anatomic shoulder replacement. We might need to go to a reverse shoulder replacement. We might need to plan a bone graft. So there's a whole more sophisticated level of understanding before you even get to the OR, just by doing something simple like having a better, slightly more detailed CT and feeding it into this software program, and then you can understand what you're doing. And we haven't proven yet that this translates into better clinical outcomes, but it certainly leads to a greater level of comfort in the OR, and hopefully one day we'll show that. Certainly in a case like this, where I'm operating here on a young patient with juvenile rheumatoid arthritis, and the 3D printed model of her glenoid that came out of that program doesn't even look like a glenoid because there's so much deformity. And there's no way in the world that I would have gotten the guide pin for the base plate for the glenoid component into the one spot in her glenoid that it was going to fit if I didn't have these tools, this 3D printed guide, which replicated exactly what I had planned on the computer. So it's exciting to see the advances in that. And the very next step has just started happening. This is my friend Joaquin Sanchez Sotelo, a shoulder surgeon at the Mayo Clinic, and he did the first case in the world recently where we can use this program to use augmented reality and mixed reality to actually project our surgical plan on a hologram by the surgeon wearing a headset, a HoloLens, and that way even closer replicate every variable that we have planned in real time in the OR. And they've just shipped our headset to arrive in Dublin soon in the next week or two. So we're really excited to be able to bring that to the next level of shoulder arthroplasty. Another aspect of shoulder arthroplasty is the challenge that we have when we have to do a replacement in a young person. Again, because that glenoid component often wears early. And so new materials can be interesting to look at. And this is a pyrocarbon hemiarthroplasty where we don't replace the glenoid part, and the pyrocarbon has a modulus of elasticity closer to that of bone, and so potentially doesn't wear the glenoid as much. And this was the first pyrocarbon case in the country that I did a few years ago. And it's just a case of, I suppose, having been exposed to that before in France, and so knowing that it existed, knowing to ask for it, knowing where to look for it, and then other surgeons started using it as well quite quickly. And so a lot of times we bring each other along too. And then the one other thing that I was going to mention in terms of a new clinical programs in shoulder surgery, the massive irreparable rotator cuff tear. So if we have patients who are too young for the bailout option, which is that reverse shoulder replacement, but we can't fix their tendon, there are sometimes, you know, limited options. And coming back to Codman, that if we have an open mind for something different, it may be better. And that's where this superior capsule reconstruction procedure came in. I think anytime there's something new, we're going to have a curve like this where there will be innovators and early adopters, and without them, we never cross that gap to actually get a majority adopting something. And with the SCR procedure, I would have been among the early adopters, and there was a lot of skepticism about it. And I think then, you know, it is a responsibility that you have to actually report your outcomes. And Ross Kingston is another shoulder surgeon in Ireland, and he and I have collaborated a lot. We work in different parts of the country, but he's a like-minded individual that I've been lucky enough to connect with, and he too was an early adopter of the SCR. And we actually set up a fellowship program together as well, a clinical fellowship program, and Albert Ferrando was our first fellow a couple of years ago. And so we reported our outcomes on SCR, and overall the outcomes were good, where we showed the improvements at 1 year and 2 year were significant, but we also were able to refine our indications by looking really closely. Certain patients, for example, those with pseudoparalysis or an inability to actively raise the arm, didn't really do as well from SCR as those who still had some better function. And so I think as we have gone along, we've refined our indications for SCR, and it did become quite a trendy procedure. The picture on the right is our first case in Ireland, which was July of 2015, which incidentally was an all-girl team, which we kind of realized afterwards and enjoyed that fact. But a lot of people wanted to try this then, and it became a thing that people wanted to visit and come watch. And I think that's where publishing outcomes and drawing attention to the indications and how to optimize the outcomes is a responsibility if you're an early adopter. And so what we do with the SCR is we use a porcine xenograft, or you can use human allograft. It's just there are regulatory and expense issues with the human one here, and we use that to essentially substitute for the rotator cuff. One other technique that's available is tendon transfers, and this is a case that I did in September, which was the first lower trapezius transfer in this country. For a long time, we've transferred latissimus dorsi, and then a surgeon who now works at MGH, but was working at the Mayo Clinic at the time, Bassem El Hassan, came up with this technique, which made a lot of sense anatomically because the lower trapezius has the same line of pull as the posterior rotator cuff. And Bassem did all the groundwork, did all the work in the lab and biomechanically and with the cadavers. And normally when you want to do a new procedure for the first time, you know, you're told to go to the lab and practice it. Well, we don't really have access to that. We don't have easy access to cadaver labs or anything like that. So for me, this was a case of emailing with Bassem, talking about the patient, saying, I think this guy, you know, is a good indication for this. What do you think? And what are the pitfalls you've learned? And he had already published one series, watching videos that he sent me and just going over the basic anatomy. And that made the case go really smoothly. So I think, you know, even if you don't have access to all of the ideal resources to start doing something for the first time, you apply all the same principles and do all the work beforehand. And to speak to that, you know, having those international contacts when you're trying to put something into practice in an area where, in a geographical area where maybe other people are not doing the same thing, is really valuable. So all of these guys that I get to be on faculty with at meetings around the world, they are an invaluable resource. And in this day and age, we can communicate so easily and send each other patients imaging. It's kind of strange to look at these pictures from late 2019 and early 2020, right before the pandemic, when we all used to just travel a lot and be together at meetings, or help, even in Australia, that top picture, help out each other with a case. But hopefully we'll go back to be able to doing that someday soon. So I think my thoughts on new clinical programs are bringing people with you, finding enough good people. And sometimes the key people are not who you automatically think of. Yes, hospital management, the people who control the financial part of things are important to be on board, but it's the people on the ground, the nurses in the OR, the healthcare assistants or ORAs, people who are going to make things actually work. I think if they believe in what you're doing, or enough of them believe in what you're doing, then you can make progress. I think research and academia do go hand in hand with developing new clinical programs. And certainly the fellowship program has made me develop more in terms of being a teacher and being accountable for what I'm doing. And we'll all have challenges. I think every single one of us will face challenges, and it is absolutely worth persevering, picking your battles, and persisting in the end. Thank you.
Thank you. That was an excellent talk. A lot of insightful points, especially about how you developed multiple areas of innovation, not just in terms of technical or procedure elements, but just in terms of infrastructure and quality control. Next, we're going to move on to Dr. Barish Edil. Again, Dr. Barish Edil is the chair of surgery at the University of Oklahoma, and he will be talking about how he developed and carried with him the laparoscopic Whipple's procedure.
Thank you, Dr. Jane, for that kind introduction. Excuse me, and Dr. Delaney for that great talk. Congratulations on your accomplishments. Being somebody of a different field, but probably same mindset, I can empathize with what you've gone through. Let's see here. So what I'm going to be talking to you about, and I'll have some slides with data and the things that we've accomplished, is pretty much the journey that I took developing the laparoscopic pancreaticoduodenectomy or Whipple operation. And this started back in 2007 when this was done maybe by a handful of people around the world. But it was very early in the development. It had been described probably about 10 years earlier than that, but it did not become part of people's practices. And when working on this, we had to develop not only the techniques, but the approaches, the patient selection. And then after developing those, transferring it to a new institution in a different environment, and then finally to my present institution at the University of Oklahoma in a different role as well as a different environment. And just to catch everybody up, as I know, not everybody is a GI surgeon. The Whipple operation is taking the head of the pancreas, the duodenum, and the bile duct, and then sewing the pancreas, the bile duct, and the stomach back into the intestine. It is a technically challenging operation, and probably why it lagged behind a little bit when it came to minimally invasive techniques. Much of laparoscopic surgery prior in the late 90s and early 2000s was really just for diagnostic purposes. And the reason it lagged behind is it may seem archaic now, but when I was a young faculty member, there was concerns of oncologic appropriateness. Where the pancreas lies is in the retroperitoneum, making it technically challenging by laparoscopic approaches. And, in the 90s and early 2000s, minimally invasive fellowships were just starting, but they were primarily focused on bariatric type surgeries in the United States. And so the path to do minimally invasive or laparoscopic pancreas surgery, there was really not one. And the reason I started looking at it was twofold. One was I was a young faculty member at Johns Hopkins, which had a very large volume of pancreas surgery, but I was a new faculty member and I was the fifth guy on the bench. So I was trying to figure out how I could get into the game and be a starter for my team. So there was some pressure that way clinically. And in addition, I was a immunologist, a cancer immunologist by my academic path, and saw an area where potentially immunology and minimally invasive surgery could join. And, my great grand scheme as a young surgeon was, can I impact the surgery where we're inducing chemotherapy earlier, and maybe at some point we will be able to get immunotherapy in there. And back then, immunotherapy was still kind of, on the fringes. And now, as you can see, it's a billion-dollar industry where it's coming into play. And ultimately, I felt, and I will show you that I learned some things where I proved myself right in some ways, and I proved myself wrong in some ways, that if I could do the Whipple operation or the pancreaticoduodenectomy minimally invasively, I would be helping my patients incredibly, because many of our patients with pancreas cancer, as you know, do not live a long time even after surgery. And if I could make this a more quality of life type operation, I would truly have an impact on my patients' well-being. This is my experience since then, incrementally through the years. And I'm going to have 3 slides, which basically talks about the Hopkins experience, the Colorado experience, and the Oklahoma experience. And at Johns Hopkins, we really didn't have a technique. It was really not common. There were few places in the country that were doing it at a somewhat regular pace. But as Dr. Delaney had mentioned, it wasn't really even in the early adopter phase of things. So the first thing that we did was I got the buy-in of my senior mentors, which without which it would be very challenging. You know, I was a brand new faculty member, and my mentors were Dr. Cameron, and Dr. Schulich was my division chief. And I said, you know, I really feel as at our institution, we should try to do this. Would you support me? Why is that support important? Well, you need, you know, a lot of innovation, I think, is done by younger surgeons. And now I'm no longer a younger surgeon. And I think that the senior surgeons supporting this, even though it may sound somewhat out there, is very important for medical innovation for twofold. One, the first operation probably took us 10 or 12 hours. We didn't have the techniques down. We didn't have the troubleshooting down. And now this operation takes us 5 hours. And unless I had support from my senior mentors in my institution, no one would ever support taking up an operating room, which could do 2 operations with one. The other issue is financial, especially in the United States. My efficiency is going to go down, but potentially it could be seen as an investment as we will be diversifying and hopefully drawing more patients to it. I was fortunate that I was at a very high volume institution, the highest volume institution in the country and one of the highest volume institutions in the world, which allowed me to execute this on a regular basis and develop it. I think it would be very challenging to develop a new technique where you're seeing that case a handful of times a year instead of every week or every month. And then ultimately, I found a partner who was going to help me, and we started developing the techniques, and we were very honest with ourselves. And this was a humbling, physically and emotionally challenging time where we were developing it, and we did about 50 laparoscopic pancreaticoduodenectomies at Johns Hopkins. And I will give you an example of part of instituting that new program and starting a new technique was the pancreaticoduodenectomy. And there was a question I think asked prior to our session of, is this still the Achilles heel? And it is. And we published on using the suture, which is a V-lock suture, a barbed suture. Now it's very common. Back then it was not common. And how we came up with the idea was I saw one of my colleagues sewing the prostate with this during a minimally invasive prostatectomy, and said, you know, we probably could use this on the pancreas. But how was I honest? Well, we published this, and we published our technique, and we were very happy with ourselves in 2014. And many institutions have incorporated this suture and this technique. But in order to shave off time back then, we wouldn't do the duct to mucosa part. We would put a stent in and we would sew the pancreas around it with a V-lock suture, because as you can imagine, laparoscopically sewing a 2-millimeter duct took time and it was challenging. So we tried to skip that step, and it actually worked. But then we honestly looked at our outcomes, and we found that our grade 3 or grade C leaks, when they happened, they were much worse than a grade C or grade 3 leak when we had a duct to mucosa suture. So then we said, okay, we got to go back, and we got to, on our next cases, start sewing that duct, and we're honest with ourselves. So I started my career at Hopkins. We developed the techniques. I felt pretty good about the techniques. And then I moved to the University of Colorado. to be the division chief. And now it was a little easier because I was a leader. So I could say, yeah, we're doing this. I didn't have to kind of get everybody aligned. And I came to a pancreas program that was not as robust and mature as Johns Hopkins. So I was able to use this as a tool to put the program on the map. I had the know-how, so the kind of first learning curve of know-how wasn't there, but I had another partner, a new partner, who had to go through their learning curve. And then I realized that there's this whole learning curve of the support staff, the nurses, the technicians, and the equipment that we needed that kind of went through that learning curve with me in Baltimore. And now this was a learning curve that I had to be patient with and facilitate. And now I felt, okay, now we got to start publishing also to kind of share these things with the rest of the world. So we published a bunch of papers showing that it was safe. And then we analyzed our first 90, and we did about 90 before I left to become the department chair. And we analyzed our data, and this is some of our honest analysis of it. We weren't being selective with patients now because we had gone over our learning curve. We were very selective at Johns Hopkins. Now we were taking patients who had comorbidities, who had prior surgeries, and you could see the operative time was around 6 hours there. We had good surgical outcomes that we proved to ourselves. Our hospital stay was reasonable. And then our area that we looked at in great detail was our pancreatic fistula leak, which seemed reasonable to us. But we did have a fair amount of interventions early on when we analyzed our data. And when we looked at our data, this again was part of a learning curve that I had gone through, but now my partner was going through. And a lot of them had to do with biliary issues, which was a learning curve. And most of these complications happened early in that. So later on, this wasn't an issue. And we, again, reanalyzed ourselves. Why did we have so many coil embolizations? And we realized that we were just clipping our gastroduodenal artery instead of tying it. This was a big deal. And we started tying it and we got that number down. So again, new program, honest self-evaluation. We saw that our operative times went down. We saw that we were dealing with more cancers, which are more difficult surgically. We were changing the management of a lot of different types of tumors that used to never be done laparoscopically, where now the majority of them were being laparoscopic. And what we decided to do was, as an early program, to say, okay, if we're looking at this and we wanted to share this with another program, how many cases does that program have to do, or that person have to do, to get the learning curve, to apply that? And what we found was the number was about 50 when we applied it. And here, we noticed that at about 50, we were doing more pancreatic ductal adenocarcinomas, which was the more difficult operation. When we hit that learning curve, our operative time statistically significantly reduced. We saw that our pancreatic fistula rate was reduced. And we saw that our complication rate and our interventions were reduced at that 50th at that 50th case, and saw these complications and pathologies that changed. We published some more on that, and basically came up with that number. I think that number has been reproduced internationally, and it's very close to the numbers that they talked about when they were looking at open pancreaticoduodenectomies 10, 15 years earlier, where the number was about 50 or 60, where people felt you passed a learning curve and you were an expert. So then our last study was, is this innovation, is this new program making a difference? And one of the areas we wanted to look at was quality of life. And the N wasn't strong enough to look at to really kind of break it down, but we used a survey. This was over a 4-year period. And what we found was, to summarize it, is the quality of life between an open and a laparoscopic pancreaticoduodenectomy. If there were complications, which 40% to 50% do have complications, there wasn't really a huge difference in quality of life. So that thing that I was trying to do with my new program and my new innovation, we did not show that if there was a complication. Now there was a subgroup where if they did not have a complication, which is about half the patients, they did great and much better. So their quality of life did improve. So it's still kind of a mixed bag of where we are. But the final lap of the laparoscopic is my University of Oklahoma experience, where I've been here for 3 years. I found another partner, and this time this partner was a minimally invasive surgeon, not a surgical oncologist, and not a hepatobiliary surgeon. I would say, and this is just kind of my opinion, early on when I was at Johns Hopkins, having another hepatobiliary surgeon as a partner was extremely beneficial. Because we understood the anatomy similarly. We were seeing it from different angles and lenses. We were developing the techniques, developing dealing with the tissues that we deal with all the time, where a minimally invasive surgeon who may be primarily involved in bariatric surgery or whatnot would not have that experience. However, at the final lap, where the techniques are now established, they're well ingrained. Having a minimally invasive surgeon I found to be very beneficial, because technically they're great at sewing and tying minimally invasively, dealing with small ducts, and we are able to kind of go through that technical learning curve quickly. Again, there's a learning curve of the nursing. What I think I was able to show by moving between 2 institutions, that new programs and new surgical innovations are transferable. It's something that if you have the right person and you recruit the right person, you can transfer that technique and that program over. And now in this area, I came to an established pancreas program. And what this has done is just simply diversified what we're able to offer as a high volume pancreas program. So in conclusion, the laparoscopic pancreaticoduodenectomy is feasible. It's equivalent to the open approach. It does have a steep learning curve. We found in our experience, it takes about 50 cases to be truly expert in it, where you're impacting your outcomes. It is transferable between programs with the right recruitment for that program. So the question is, should you start the program? And I think that's an individual choice, looking at your institution and seeing if this is a facet that you want to add or not. But ultimately, I think that this has been a new program that has kind of traversed the United States as I traveled through my different positions. But this concludes my talk. I want to thank the American College of Surgeons, Dr. Jane, Dr. Delaney, for allowing me to give my talk. And I'd like to thank people listening for giving their time to me. Thank you.
Thank you very much. Excellent talk. One of the common threads I see from both of you is that a huge part of this is engaging people properly and surrounding yourselves with the right people, and also being able to develop a way to keep track of how well you're doing in real time in terms of your progress, your outcomes. I will ask a question at the beginning, and then I'll open the floor. So in terms of one of the things I'm most interested in addition to the actual procedure you bought, Dr. Delaney and Dr. Edil, have others adopted have you been able to actually gain traction from some of the quality and outcome assessment measures you developed, like Dr. Delaney, for the shoulder surgery, you brought a new way of measuring your outcomes and your quality and patient pain scores. I mean, have other people who are not doing shoulder surgery, even general surgeons or other people, I mean, has this kind of caught on in a way?
It has caught on a little bit, that particular aspect of things. I think still in this country, the infrastructure problem is a challenge. I know that one of the foot and ankle surgeons started to use it not long after I started to use it, and it's sort of slowly gaining traction. Some people are still maintaining just their own sort of individual databases, not part of kind of an electronic, cloud-based system. But certainly that surgical outcome system, once I had kind of broken the ice and gotten it approved, it became easier for some others to start using it.
That's great.
Thanks for the question, Dr. Jane. These techniques have been shared both internationally and nationally, and people have taken the techniques and probably added their own adaptations to them. Ultimately, I think it has incorporated in other institutions, but those institutions were always high volume institutions, and they were able to incorporate and change their program around this. I think there are some individual surgeons who have learned them and taken them on into their practice and in their careers, but programmatically, as the title is, new programs, only in the high volume programs has it been successful.
No, I think that's a very good point. It's not just the seed, it's the soil, because to learn how to do 50, if the learning curve is 50 laparoscopic Whipples, obviously not everyone who comes in the door is a candidate for it. People with locally advanced or borderline. So you probably have to have a program that sees 200, 250 pancreas cancer cases a year to be able to get 50 cases that might be a candidate for the surgery. So there is just from that perspective, in terms of clinical volume, a significant barrier of entry, I would think. The other part of it, I guess, for Dr. Delaney, a lot of the innovations you brought require money, especially in places where they have nationalized healthcare systems, like Ireland. How did you make a case for resources when you first got on the ground? Dr. Edil said, in the United States, one of the barriers of entry for him was that he has to take up an entire operating room. But the logic was, at a program like Hopkins, where it sees a lot of pancreas volume, this is another tool to add into the toolkit. How did you make your justification in terms of the software, the resources, and get money that you needed?
It's a really great question. It's an important point. So for people who are not familiar with Ireland, we have a socialized healthcare system, and then we have a private system that is probably taking care of about 50% of the population who choose to buy health insurance, because the public system really just doesn't have the capacity to take care of the whole population. The public system is quite similar to the VA in a way, except that it's for everybody. And so I work in the private system, and in one way, it's maybe a bit easier to introduce innovations there, but in another way, the financial controls are tighter. The public system, it's the taxpayers' money, and there's surprisingly and unfortunately very little accountability. So bringing something expensive to a public hospital, whether that's expensive in terms of OR time or implants, which is a lot of what comes into play in orthopedics, it's actually easier in the public system than in the private system. So I really had to fight quite hard to say, well, value in healthcare is your outcome divided by your cost, right? So if you are just driving down the cost all the time, but you drive down the outcome as well, you don't change the value. If you have an increase in cost, but you can show an increase in outcome, then you're providing better value. And healthcare in the privatized way, being a business, if you're offering better value to the patients, or if you are doing a procedure that is not available in every part of the country and every hospital, then people may come here for that, and that in itself would generate more business. But it was a tough sell, and the OR time thing is very real. One of the established, probably the main established shoulder surgeon when I arrived, was high volume and a very fast surgeon, and kind of, did things his way, and that was that. And I think in the first probably 2 years, a lot of people just thought that I was just, not really any good because I was taking up the OR for longer and doing these other things. And then slowly people started to get on board. So I think the outcomes part was key in making my case, and also just sort of promoting the idea that we should be a center of excellence. And that was very much the vision of Sports Surgery Clinic and of the Beacon Hospital too.
Thank you. I've got some questions from the audience from Dr. Faisal Altabi. Thank you for this great webinar, fantastic speakers. What is the best methodology to measure surgical outcomes based on the case complexity? So I guess the question is, are you able to control, similar to NSQIP, the complexity of the case? I mean, is it built into your metrics where you're doing a more complicated case, you might expect a higher complication rate versus a less complicated? I mean, does your outcome software account for that?
That for me in orthopedics?
And I think for both of you. When you measure your metrics, are you able to control for case complexity in terms of when you're doing a novel, innovative procedure, judging your complication rate?
Sure. I mean, we enter that into the database. We record the metrics in terms of the starting diagnosis, and we tend to group the cases together. So I guess the short answer is yes, we can control for that.
So you cohort like groups of patients or case severity or comorbidities, and that allows you to, okay. Another question is from Burkhan Nasser. According to the size of pancreatic cancer, are there different outcomes between the use of minimally invasive or open surgery? So I think they mean tumor size, or are there variables that basically contraindicate a laparoscopic technique based on size criteria or others?
Dr. Nasser, thank you for the question. I think the minimally invasive techniques for pancreas cancer, in the United States, it hasn't been adopted widely. There are institutions that do it. It is not an uncommon thing, like back in the early 2000s when I had started it. So large institutions in the United States have adopted it, but it's not widespread. This isn't where every institution has this technique. I had visited China, which is a group that I collaborated with over the last 10 years who have adopted these techniques. And there it is very widespread. And almost every institution that deals with pancreas cancer has somebody who does this operation. So to your question, how do you select people for it? Which is, I think, ultimately what you're asking. And I think for every surgeon, it's very different. And I think there are surgeons who are willing to go to great lengths and do minimally invasive portal resections and things like that. But I'll share with you what I do. If a patient is resectable, by our definition of resectability, where the portal vein, SMV, hepatic arteries are not abutted or involved, I will offer them a minimally invasive technique. If the patient is borderline, where in the United States we give them neoadjuvant therapy or chemotherapy before surgery, in those patients I will not offer them a minimally invasive technique, as the desmoplasia and whatnot becomes challenging for me laparoscopically to tell the difference between that and cancer, as well as I feel that the safety component, as well as this time infused into trying to deal with the portal vein laparoscopically, does not outweigh the benefits. So in summary, the selection criteria is loose, but if they have a resectable cancer, I offer it. If they have a borderline cancer, I don't.
One more pancreas question, and I think that your slideshow addressed part of this. Is from Dr. Merab Kiladze, I'm sorry. What do you think of the efficacy of transanastomotic and external drainage of the pancreatic duct at pancreaticoduodenectomy? We're using this technique with a good result. It looks like you do transanastomotic stenting. So So I don't know if that's distinct from drainage, like do you use an external drain as well?
Yeah, thank you for the question, Dr. Kildaze. So what I would say, I'll answer this in two things so there isn't any confusion. The internal stent that's in the pancreatic duct, where I had a picture of our publication, where the stent is connecting from the pancreas to the intestine, I do not think that decreases our leak rate, but it is something that I use for technical reasons, as sometimes the duct can be only 1 millimeter or 2 wide, and as we're sewing it so there isn't any stenosis of that duct, we will leave it behind and let it pass on its own for technical reasons. External drainage of your anastomosis, I think, is a must. There has been a randomized trial in the United States that stopped between drainage and no drainage because the no drainage people were dying. And so I think that the external drainage should be routinely done on every pancreaticoduodenectomy.
Are there any other questions from the group? I'm not seeing any more in the question box right now. Let me ask just one last question or two. So Dr. Delaney, what do you think I mean, obviously you brought something, a totally different program, not one that you developed in your own country and, going to different institutions. You brought something novel, really de novo to an entire country, incorporating, using the resources of the healthcare system. What do you think your biggest challenge was? If you could summarize all the challenges, what was your hardest thing to tackle?
I would say the thing we touched on earlier about having the freedom to use more resources in the beginning and just to have others tolerate your learning curve. It's really interesting that in pancreas surgery, you're seeing that the learning curve is 50 cases. That's what we've seen in new shoulder procedures as well. And I think the biggest challenge was that I was doing this in my second year in practice. And so having people just take me seriously and tolerate that learning curve and that time. And I think just finding the right people and the right hospitals that would allow for that. And I think that's a tough time at the beginning because you're not sure that what you're doing is going to pay off and it's going to work out. And it's good that you question yourself a little bit, but I think that's the biggest challenge, is just finding the space for your learning curve.
Dr. Delaney, the slide I saw of yours that I thought was hilarious was you're coming with this super specialized technique, and the board said you needed another fellowship.
Yeah, I mean, you couldn't do that stuff.
It's just hilarious.
Yeah. So I tell you, this is one of the things I do want to commend both of you on is to actually have the courage to do something different in an environment that's not supportive. I mean, I was with Dr. Edil at Hopkins in 2006 to 7, and it's a conservative place, especially in terms of pancreatic surgery. There's a long established tradition, and as a brand new faculty member to bring something new in an environment where people have very strong opinions and judgment, for you as well, Dr. Delaney, bringing something where there's an established tradition of training that everyone goes through, and you've kind of done something a little bit differently. And then on top of that, to engage in a track where you're exposing yourself to criticism, I think it really does. I think surrounding yourself with good people, going about it the right way, I think tactically you guys navigated a lot of barriers, which is something we can all learn from.
Thank you. Thank you, Dr. Jane.
Thank you very much.
Okay, this is a pancreas cancer one from Dr. Burkhan Nasser. What is the best palliative surgery for unresectable pancreatic cancer with gastric outlet obstruction?
That's a great question. And I think there is some debate over which technique would be better. Here in the United States, many times we will put a duodenal stent in to help with that obstruction, which I think probably works quicker, but has less durability to it. Another option would be a laparoscopic gastrojejunectomy, which has more delayed function, but more durability. So I think you have to just look at the patient and where they are in the course of their life. And if they have a month or 2 months to live, potentially doing it endoscopically would be beneficial. Or if you think they have 6, 9 months, a year to live, maybe surgically would be more beneficial. But those are the two options that we typically do for gastric outlet obstruction from pancreas cancer.
Thank you.
So I just want to let everyone know that the webinar from today will be available online. We strongly encourage you to share it widely with your colleagues, and you will receive an email when it is posted. If you have any questions or follow-up, please contact me or Tony Ortiz, my colleague. Our email addresses are here. You can also text me through WhatsApp. My number is up there. If you have any questions about the webinar, becoming a fellow of the college, or any of our other programs or resources. Again, you can follow us on social media for more information. The International Relations Committee hosts a series of regular webinars. We have some webinars coming up on the He for She initiative that we hope you'll turn into in May. So thank you so much for joining us. Thank you to our panelists, and thank you to our moderator, Dr. Jane, for organizing today's webinar. Have a great day.